All right, so let's go to the patient list and search MCG_DA. And then you will select, don't double click, just find the patient Nadia, Nadia. And then MCG_DA. You can, search the whole thing _Nadia, NAD. And then you find the best systolic phase, which is the 34%. Right click and cardiac. So I'm going to give you about a minute or two. Just let's go through it quickly, and then we can point out the main finding. So we're just going to clean up the 3D volume render images. All right, so a few more seconds and we can, any volunteer for this case? What do you see? Myocardial bridging. Okay, so just to kind of spend a few minutes on this talk or this topic. So myocardial bridging, just to go through the images, there's no plaque for this patient. Calcium score was 0. I selected a systolic phase just to show you the dynamic component for this patient. So I just saved this from before, and you can really appreciate how the artery is so squeezed during systole, almost like 80% stenosis. So how would we report this when we see a patient with myocardial bridging? So I have a few slides. Just so this is, again, this patient, a 65-year-old, came with some chest pain, outpatient. This is the, just to show you the myocardial bridging. This is a diastolic phase. I saved it here just to show you the contrast of the difference between systole and diastole. So now, just a few points about the myocardial bridging, things to keep in mind. One is what's the definition? It's like an epicardial artery diving just below the myocardial surface. The way we look at it, we assess the depth. So by definition, we go by up to 2 millimeters, still superficial. 2 to 5 is deep, and 5 and above becomes very deep. And then the length, we go by 2.5 centimeters. So once it's 2.5 centimeter or more, becomes long segment. So these are two components we try to pay attention to. And then the other thing, you try to assess if there's any proximal or intra like segment stenosis. Sometimes you might have some proximal stenosis to the myocardial bridging. This is another kind of way to look at it. Again, the depth, 2 millimeters is the cutoff you need to remember, and 5 and above becomes more, it's called very deep, and then the length, 2.5 centimeter. This is more just to kind of point out there are a lot of options. You can treat these patients. That's not the goal here. But remember, this is a dynamic condition. So anytime you see some myocardial bridging, try to find a systolic phase as we did. So if you go to that systolic phase we were just at a minute ago, you will appreciate the kind of systolic compression. If I go back to a diastole, as I showed before, it was less compressed. So there is a compression here. And then the other part we talked about is when you report, you want to assess which segment is involved, length, depth, if there is systolic compression, and then the proximal plaque stenosis. To some degree, LAD is the most common segment, followed by sometimes OM and RCA. We'll talk about the CAD-RADS later on, but this is one of the points that you will use the modifier, the E, when you have some myocardial bridging. The question that comes in mind, do I need to report every myocardial bridging in the impression? Again, the different really opinion on that. The way I report, especially for young folks, if it's a very short, superficial, not even 1 millimeter, I don't need to make much out of it. Sometimes I just put it in the body of the report. But when it becomes long segment, deep segment, or there's some systolic compression, then it does make sense because this patient can become symptomatic and show some ischemia. So that's for the first case. Any question before I move to the next case or any point?
So one thing to help you remember that, I think of a bridge as a relatively short, and then I think of a myocardial tunneling as the longer one. So it's not official, but if you've got a tunneled or 25 millimeter section, you can think that that's more likely to be significant, which aligns with everything. So sometimes I'll call that myocardial tunneling for a length. But if you talk to the cardiac surgeons, they'll say virtually everybody has short bridges, when they're in there. And you'll see this more and more at CT.
Great. It's very helpful. Thank you.